Uh, Thank you for joining us. And as I look outside the window at the moment, it's -4 and the garden's full of snow. So for those of you in Australia, please enjoy the warmth because we're not feeling it here. And our study days that we've held have been in bad weather occasionally, so people really haven't been able to travel. So this form of presentation, I hope, is going to improve the information, but without the travel. So very specifically, I wanted to talk about research, and this is mentioned time and time again amongst women who come to the workshops. How does research that is carried out by health professionals translated into clinical practice? And this is a very important area for clinicians to appreciate, because if we produce the research that produces the results, you as patients need to know how you can access that treatment or those results. Very basically, clinical research is any form of gathering data, information and facts so that we can advance our knowledge. And there's many forms of data. Particularly in vulval pain, we see a large amount of qualitative data which has quite a large question base, and themes are looked for rather than numerical results, whether a treatment works or not. So this is quite analytical. An example of qualitative research for vulvodynia might be, for example, the experience of women who've undergone treatment, or the partner's experience of their partner experiencing vulval pain. Quantitative, usually you're going to get numbers. It's a specific question. It might be, does treatment A work over treatment B? Prospective versus retrospective data. Again, this is important because if we look back through hospital sets of notes to see if treatment X worked for vulvodynia, invariably we get gaps in our knowledge because the notes are incomplete or people can't recall certain things. So prospective data is much better, so those studies are always going to be stronger. Trial designs, well, there's a real thumbs up for systematic reviews and randomized controlled trials, which are going to be the best way of assessing whether treatment A is better than treatment B. Randomized controlled trials where a treatment is randomized against usually a placebo or another treatment, and the patient who's eligible for the study has a coin tossed by the trialist, and the patient is randomly allocated to treatment A or B. That eliminates bias, and that generally gives us the best answer to the question, and takes away any sort of professional bias or any leaning towards an outcome. The weaker studies, case series and case reports, well, they're really just small groups of patients with a condition who've had a treatment, and we can't really generalize that treatment to everybody. So they're just to bear in mind when you're looking at the literature, and there is much on the internet on research related to vulvodynia. Why is it important? It's incredibly important because all our clinical practice is based on good quality research, and if we have research, we have evidence, then these are incorporated into guidelines endorsed by medical colleges and disseminated widely amongst clinicians. And this is happening with vulvodynia. I'll come onto that on the next slide. Potentially, we've got, through NICE, which is the National Institute of Clinical Excellence, which is based in the UK, we've got the potential to influence the national practice. If a guideline is endorsed by NICE, generally, people will wake up, particularly the commissioners or the buyers of services of hospitals. They will purchase services related to a condition if this is endorsed by this organisation, and they look at all the evidence available. So without research, we have very little. So just to bring you up to date with what's happening in the UK, and this is a guideline for the management of vulvodynia. Now, I was part of this group, and we're a mixture of doctors and a patient representative, Fabi Brackenbury, and this was published. We looked at 50 high-quality papers in the medical literature to support a series of guidance for general doctors working in women's health, that's GPs and hospital specialists. So we tended to exclude small studies that weren't particularly well controlled or or case reports, studies which really just had very little conclusion. Even then, when we look at vulvodynia, there's still very little in terms of good quality research out there. And I've just picked up a few random points from the guidance, and you might think this is incredibly straightforward. And for the first point, an adequate pain history should be taken to assess the degree of symptoms and the impact on the woman. I mean, you might think, well, that's pretty straightforward for a patient who's got vulvodynia, that you take a pain history. But we know that many health professionals still treat vulval pain with Canesten or an antifungal. They think of the problem as a skin condition rather than a pain condition. So that's why that simple level of guidance is there, and that's based on evidence, because vulvodynia is a pain condition. A team approach may be necessary, absolutely. You do need a team approach for vulvodynia. You need to combine treatments, and a couple of other things I've mentioned there, techniques to desensitize the pelvic floor. They can be beneficial, and intralesional injections may be considered. Again, these are treatments based on evidence. Somebody has gone to the effort of trialing these treatments and publishing them in the literature. The problems with vulvodynia and research, however, are that you get incredible varieties in outcome from medical, surgical and behavioural, or behavioural would be sort of psychological, psychosexual therapy interventions. And this is for a number of reasons, and this might help explain why we simply haven't answered the question, what is the best way of treating vulvodynia? Well, different doctors make different diagnoses, so a woman who presents with vulval pain may have a different diagnosis made by different health professionals, and a woman with vulvodynia might get a different assessment between different doctors. So inclusion criteria can vary. As a rule, we should distinguish between provoked and unprovoked pain for clinical trials, but the reality is many women have a combination of the two. Follow-up rates vary. A treatment might give benefit at 6 weeks, but however at 6 months, a year, it may have worn off. So really, that's a very short-term benefit of a treatment. It's the long-term benefit that we're really interested in. Placebo, I'll come on to it in a sec, but very important. Does the treatment really work, or is there a placebo or effect, or is there a sort of would a dummy treatment be equally as effective? And very important, outcome data. To this date, we still don't have good quality outcomes, and you know, how does your doctor assess whether you've had a good outcome as a result of the treatment that he or she's given you? Well, you could ask, the doctor could ask you, are you the same, better, worse? Or you could fill a questionnaire in, a standardized questionnaire, which is quite useful because you can score a lot of your symptoms, and And examination, that's another way of assessment where you'd use a Q-tip swab just to touch the vulval area, and if it was painful before the treatment and painless after treatment on the Q-tip touch, then that would indicate that maybe that treatment worked. But we still don't do this very well. Really, it's probably a combination of outcomes we need to look at. And then treatments are empirically based. We tend to just give treatments we think will work as health professionals. Here's a quick picture of a simple visual analog scale, and you get a score from the level of pain. And scores are helpful when it comes to research because we can compare pre and post. We can compare pre and post treatment. Placebo is very important, and I'll just talk about lidocaine gel. And lidocaine gel is very commonly used for vulval pain. It's an anesthetic ointment. It's a numbing agent. It offers patients a fairly quick fix if they've got pain. It can be applied 2 to 3 times a day. It can sting for some patients, so you have to use it with caution initially. But this original study showed that if you use lidocaine overnight for vestibulitis, what we used to call vestibulitis is now Vulvodynia, but if over 7 weeks, 76% of patients would be able to have sex compared to 36% of patients before the treatment. And that would be very encouraging as a treatment, and the lidocaine would smother a cotton wool ball, and that would be placed into the vagina nightly for 7 weeks. But this was a case series, there was no control arm. We do have another study, however, that looks at the use of desipramine and lidocaine for vulvodynia. This is a randomized trial, a better controlled trial, where patients were randomized to one of the 4 groups below. Desipramine is a drug for neuropathic pain. It's taken by mouth. It's a bit like nortriptyline or amitriptyline. But the point is, those patients, when they had lidocaine cream and placebo, compared to those patients who had placebo cream and placebo, there was a greater reduction in pain level for those patients having the placebo cream, the lidocaine cream, even though the patients with the lidocaine cream did improve. So we just have to be careful when we come to treatments that it may not be the treatment that's working, and a dummy treatment can, the dummy treatment may do as well, or if not better than the treatment. And this is just a well-recognized fact of research. Placebo response is significant. I'm just going to focus on perhaps a bit about pain and more the science of pain. And one of the questions we get asked at the VPS is a bit about nerve endings and skin. And the picture there shows a variety of different pain, touch, hot, cold sensors in the skin. And we all have these as a normal part of skin function. In vulvodynia, we used to believe that there was an inflammation or a redness or an angriness in the skin that gave pain, but now we don't believe that, because when the skin from women with vulvodynia is being compared with the control skin, there doesn't seem to be any difference in the inflammation that's there. So it's not an eczema or a virus or a precancerous change in the skin that's causing the pain. We think there's probably an increase in the local blood flow, and the reasons for that aren't clear. But there is evidence to show that perhaps there are more nerve endings in the skin and an increase in the pain-producing chemicals produced at the tips of the nerves. So there's the nociceptors there, which detect pain. The chemicals calcitonin gene regulatory peptide and substance P. These are two chemicals produced at the tips of these nerves. And again, scientific research would suggest that in vulvodynia these are increased. Skin, I mean, the reason why vulval disease becomes difficult is for many health professionals because skin is a surface, vulval skin is thinner, and there are lots of chemicals going on the surface of skin, and this is a simple biopsy cross-section of skin under the microscope. You've got a top epidermis, which is a protective layer, a dermis beneath it, which is less protective, and within that are the blood vessels and the nerve endings. So in this section of skin, you've got a whole variety of nerve endings which are beyond the naked eye and the light microscope, networking through the skin. So one of the questions that we often ask is, why vulvodynia? And I'm just going to finish off, just talk about two bits of research that's been carried out, only not 2011, 2012. Many women with a history of vulvodynia, with vulvodynia, report a history of recurrent thrush. There's a series after series, study after study show that women with vulvodynia have had thrush treatment or have had recurrent thrush in the past. And it's almost the norm that antifungal treatments have been used. And we know that Candida is very common in the vaginas. So the question is, does thrush, vulval thrush, develop into vulvodynia? Because there's an important message there, because recurrent thrush is incredibly common in the population. Now, it's hard to prove this in humans, so this one study from 2011 aimed to create to recreate a thrush model in the laboratory using mice. So this was a series of experiments using mice where thrush was induced into the mice, and then they were treated with an antifungal soon after. And there was a series of experiments, and the mice had thrush introduced into their vulvas and onto their hind leg as a control, and there was another control group who had saline. So this is basically laboratory-induced thrush in animals, and this was repeated attacks, and this was a sustained attack of thrush on the mice. They then assessed the skin to see if there was an excess of nerve fibers. So how do you assess vulvodynia in mice? Well, vulvodynia exhibits a phenomenon called allodynia, where when the skin is touched, there is an excessive pain rather than touch. So this is called allodynia, and this is the perception of pain when there is touch. And this is a problem of nerve endings rather than the skin. This is the central processes going wrong in the brain, a memory of pain. So the brain is integral in the perception of pain, and so and it is integral in the sensory feeling of pain when the skin is touched. And in this experiment, the vulvas of the mice were touched, and the hind paws were touched with what's called a von Frey fibre, which is like a small hair. And when the hair bends, the pressure can be measured. Now, if there's pain, usually there's a bit of there's a recoil response to the tip of the hair. So, what were the results? Well, there was a series of experiments, but what they found was when the mice were given 3 consecutive doses of Candida with antifungal, so they had 3 attacks of thrush. They noticed that 40% of the mice had allodynia. So the first 2 attacks of thrush and treatment, the thrush was treated and the symptoms settled. The mice were not touch sensitive. They weren't allodynic after 2 attacks. But after 3 attacks, when the infection was cleared up, they still remained hypersensitive to touch. Another experiment showed that if it was a single prolonged attack of Candida and the mouse wasn't treated for many days with antifungal, that this led in a significant proportion of the mice to touch sensitivity in 86% of the group, even after the infection was cleared up. Zymazin is a chemical a bit like Candida. It's a part of the wall of the fungus, so it's similar to Candida. So Zymazin was also given to the mice, and a lot of the mice experienced allodynia when it was given repeatedly, but the response was very variable. So 1 mouse out of the 19 had touch sensitivity right the way through the entire experiment, but many had allodynia only after 4 or 5 weeks. So in conclusion, really, what the research is showing that you can produce an allodynia or touch-sensitive response with recurrent thrush. They looked at nerve endings, and this slide basically, should we go from left to right, this is basically the picture that you get when you stain nerve endings. It's different to the previous picture, but you can see the epithelium there, and PGP is the stain they use. And this is the control group, mice with saline and fluconazole, which is the antifungal, Candida and fluconazole without allodynia, without touch sensitivity, and this third picture is Candida and fluconazole with allodynia. And this is from their paper, and it shows basically when the mice were allodynic or they had touch sensitivity, there was an increase in the nerve fibers as demonstrated on this picture, and they counted these. So I think the message is that we feel that there is something in the fact that recurrent bouts of thrush may develop into vulvodynia, and that this recurrent infection can produce a neuropathic pain syndrome. So we need to push really for early diagnosis of recurrent thrush and early treatment before a pain pathway sets up. However, it doesn't explain other things like herpes. Herpes is a very nasty inflammatory condition of the vulva, and we don't know really what the nerves were doing before the mice were treated. But I thought it was encouraging to see such a research study done because it lends much more evidence to vulvodynia being having a physical reason or a sort of organic reason for pain developing. I know there's a huge psychological, psychosexual aspect to the problem, but it's not purely psychological, psychosexual. I think this sort of research gives us a bit more of an understanding into perhaps reasons why nerve endings develop. The genetic link is interesting in that that we think there may be a pain gene, and so certain individuals are more likely to develop pain than others, and this may be relevant to vulvodynia. So moving on to a treatment. Now this paper was produced only last year in one of the medical journals. For it to be published in the medical journal, it has to be peer reviewed by a variety of reviewers and then submitted. And so it's subject to some scrutiny. And the question was, does enoxaparin injections help in the treatment of localized provoked vulvodynia, touch sensitivity, the allodynia problem that you get in localized provoked vulvodynia or vestibulodynia, so painful sex, pain during tampons, etc. That would be that group of women. And enoxaparin is a standard treatment that we use in the hospitals all the time, and we use it to prevent blood clots in the leg and in the chest, and we give it as a self-administrated injection into the fat, not the vulva. And the group that did this research had done a lot of work showing that in women, not animals now, women, the nerve endings in vestibular skin are increased in number, and there is an increased number of mast cells, as shown in the picture, and heparinase activity. Heparinase is essentially an enzyme. It's a dissolver. It weakens the cell wall, allows nerve growth, and mast cells are protectors of infection in the skin, and they're important for allergy and anaphylaxis. So these are important cells in the skin, and we know that enoxaparin, which is the injection, blocks the heparinase. That's the dissolver, the enzyme, we call it, that protects the mast cells. Now, if heparinase acts on the mast cell and weakens it, there may be an increase in nerve endings in the skin. This was the hypothesis that they were working along. A heparinase, presence of heparinase in the skin weakens the heparin sulfate, which is the protector of the cell, to weaken the mast cell and the nerve growth. So, randomized controlled trial, 40 women with the symptoms randomized to one of two groups. One was placebo and the other was the treatment arm. And it was one injection a day of Clexane or enoxaparin for 90 days, and the other control group had saline for 90 days. Unfortunately, these part of the trial, you needed the biopsy before and after. And if we drill down into the figures, this is a hospital or a team that have a big interest in vulval disease. Of the 224 women that were suitable for the treatment, we were getting only 40 randomized because many women weren't happy with the biopsy. And what are the results? Well, you can see that from this table, along the bottom it says end of treatment, further along end of research. Well, in the black is placebo and the grey is the actual treatment. We can see that there are greater responses in the patients treated with enoxaparin than placebo. So there was 75% of the women, i.e. 13 out of 20 women, had more than a 20% reduction in pain level compared to the placebo group. But again, look at the placebo group. Out of 18 patients in the placebo group, 5 of the patients, 27%, had more than a 20% reduction in sensitivity. So the placebo group here is significant. So the data is promising. 7 treatment patients and 3 placebo patients had painless sex at the end of the study. And so these women also had biopsies before and after, and if they improved with the treatment, they had a reduction in the number of nerve endings in the skin after treatment. So these are women who had 2 biopsies. They improved with the Clexane injections. They had a reduction in the number of nerve endings in the skin. So does it work? Can you take this away as a possible treatment? Well, we answer one research question with another, and they certainly didn't suggest that this was for everybody because of bruising, expense, administration of the injections for 90 days, there was a big improvement with the placebo group, but possibly there is a subgroup of patients with vulvodynia who may benefit from this, but it's watch this space. But it's research like this that has, you know, small acorns grow trees. We hope that this sort of research progresses and develops, and it's only through asking questions like this based on science that we will get the answers. This is a trial website that the NHS has, National Health Service, which has a lot on research, and there's not a huge amount on vulval disease, but it's nationally it's the site we would go to where we would look for clinical trials. That's NHS Choices. I'm going to finish there. All I'd say is that I think we still have lots of questions to answer, and it's not all high science. Research can be about pathways of care which are still unclear, and research will decide whether a pathway is good or not. I've chosen those subjects because it's the first webinar, but clearly if you have a research question you want answering, it's more physical treatment based, then we're happy to do a future webinar. And the last thing is to mention the online research projects that are on our site, because there are a number of qualitative studies looking at women with vulvodynia and partners with women with vulvodynia that you can do online. So all the information we can get, the better.